Good evening. Welcome to Passionate World Talk Radio. And tonight, Maryanne Matz presents her program, Everyone Dies.
This show does not provide medical advice. If you're having a medical emergency, please call 911. Anything you hear here should be discussed with your primary health care provider. This show is intended for the adult listening audience, and listener discretion is advised. Hello, and welcome to Everyone Dies, the radio show produced by Passionate World Talk Radio, whose goal is to educate, enlighten, and entertain. I'm Maryanne Matz, and for the next 30 minutes, I am your host for this live call-in show. Please call 484-258-1876 with your questions. That is 484-258-1876 with your questions. Until we hear our first question, I thought that I would chat with you a little bit about why do people die. And there's a lot of ways that people think about why people die, and one of the first is that of a religious point of view, where in most religious circles, death is a punishment for sin. Adam passed on the effect of sin to all of his descendants. And the Bible says, though one man's sins entered into the world, and death through sin, and thus death spread to all men because they all had sinned. Therefore, according to the Bible, all people die because they all sin. Islamic scholars, they say life is a test that ends with death. Every soul shall have a taste of death, and we test you by evil and by good by way of trial. And Christianity actually also shares a Judgment Day type vision. Galileo was instrumental in the Figure It Out Yourselves movement. This was the idea that death was not necessarily God's will, but partly something that we could control. Science, penicillin, C-sections, and immunizations, all of
Passionate World Talk Radio.
that in the past have been accounted for by God's will.
I have a question for Dr. Matz, please.
We have someone on the line who has a question for you.
Hello, you're live on the air. How can I help?
Yes, I have a family member at home who's nonverbal. How do we know if the patients are working when Palliative Care is here caring for them?
So what you're asking is that you have somebody who's in the home, and you're wondering if they're not able to say for themselves if the pain medicine is working. Is that correct?
That's correct.
So there's things called subjective and objective data. And so this is from nursing, right? Subjective is anything that the patient can tell you. And what you're saying is that the person isn't able to tell you, yes, I'm having pain, and I can rate it on a 0 to 10 scale this way. But we also have objective data, things that we can see. So there are things like, what is the person's pulse rate? A very fast pulse rate, especially when somebody is ending toward the end of their life, can be indicative that they're having pain. A higher pulse or higher blood pressure could also indicate that. Sometimes you'll just see people picking at their bed sheets. They're really not able to move a whole lot, but there's that fine kind of just picking, just moving, that restlessness. It can be a very fine kind of restlessness. And, because they're in the home and because you've been taking care of them, you can say, why is he or she doing that? And that might be your only indication that they're having some pain. It won't hurt them to give them some of their pain medicine, and then you could say, oh, they're much calmer when I give them their pain medicine. How fast they're breathing, whether or not they're able to sleep. If they're restless in their sleep, it could be because they're having pain. So looking at those objective signs, what you can see, will give you an indication. And my rule of thumb, especially if it's somebody who's at the end of life, is to say, if you think they might be having pain and there's pain medicine prescribed and you haven't given it in a while or ever, then give them, the low dose, the first dose that's prescribed, and see if they seem more comfortable to you. There's no rewards for being at the end of your life and not having your medicine to feel more comfortable. So feel free to use it if you see any of those objective signs. Does that make sense? Do you have?
That answers my question. Thank you so much.
Perfect. Thank you for calling.
Okay. Take care. Thank you.
You too. Take care. So the caller asked a really good question, because you're not always able to get an answer from people about how they're feeling or what they need, but kind of tuning in, watching how somebody is responding or not responding will help guide you in terms of, do they need their pain medicine? Do they need their anxiety medicine? Looking at what position they're laying in, if they're able to move on their own. If they're having pain in one spot, they might be protective of that area. So until we get our next caller, I was talking about why do people die in religion. Buddhism and Hinduism are also have a view of death as the end of a test. And at the end of that test, and meaning after death, it's followed by reincarnation. And reincarnation in the next life is determined by the quality of one's acts in this life. So when you rise above the test, rising above preferences, you become liberated. You find nirvana, or you're enlightened. And this enlightened state isn't separate from this world, but it's a release from the suffering of this world. So the other thing to look at, other than mortality, is that we have, aging is a part of why people die. And the larger the population that we have, then the larger death numbers we have. And so around 1910, we had our first baby boom. And it wasn't that there were only more deaths in that period, but those babies didn't die. So when you're looking at infant mortality, it's looking at the number who die in a given year of birth with those
Passionate World Talk Radio. Do you have a question?
Yes, I have a question on Do Not Resuscitate with Dr. Matz.
Hi, you're on the air.
Yes, I have a question about the use of Do Not Resuscitate orders. Can you talk about how those are used by physicians and what they're meaning and how the family should think about them?
That's a really good question. So Do Not Resuscitate orders are orders that are written by a physician at the request of the person who is having a life-threatening illness. So if you have, let's say, end-stage heart failure, and you go into the hospital and you say, if something happens where I'm not able to breathe or my heart stops beating, I do not want to be resuscitated. Well, that decision has to be written as a doctor's order, and it has to be written every single time you go into the hospital. So to have a Do Not Resuscitate order, or to have that in your DAN's directive, doesn't count, I guess, if you will. It has to be a written order every single admission. And so what does that mean? It means that if in that event, in that hospitalization, if your heart stops or if your breathing stops, they are not going to use any artificial means to try to bring that back. And there's good reasons for that. We see resuscitation on TV, and it looks so nice and clean, and people survive, and everybody packs up and goes home, and it's just portrayed not at all like it really is in real life. To press on the sternum to try to keep the blood circulating, to make the heart beat, to manually make the heart beat, is very, you have to press with some force. And what often happens is that there's ribs and bones that are broken in the course of that. And being shocked if they use electricity in order to try to restart the heart, putting a tube down the person's throat, and in the hospital they are taken then immediately to the ICU, where that person is put on a ventilator, a respirator, to breathe for them. And then the next phase of that, assuming that they're able to get a heartbeat and stabilize the body, is to figure out what happened, treat it with whatever medication, and then try to get that person off the respirator. So do not resuscitate orders are orders that are written for the person who's decided that they don't want extraordinary means in order to maintain their life. Now, is that what you wanted to hear, or was there a more specific question about that?
Well, yes, that's what I wanted to hear, but in light of the
Passionate
ongoing pandemic...
I think he disappeared, but we have a new caller. Passionate World Talk Radio. Can I help you?
Hi, I have a question. I was wondering if you have family members who maybe are hesitant to talk about end-of-life care, are there some tips or tricks you have about getting them to kind of come around?
Hi, that's a really good question. You know, there's taboo subjects at least in the United States. One of them is typically sex, and the other is typically death. And I think, at least in my experience, sometimes people are more willing to talk about sex than death. And it's one of those that if people say, I don't want to talk about that, I want to talk about something happy, or I don't want to think about that, saying, here's why I want to talk about that. And if you don't want to talk about that right now, can I bring this up in a month or in a week? Assuming that it's not something like they're being admitted for very serious illness, where you have time to say, there's some things that we need to talk about, like an advance directive and what it is that you want. And maybe say to them, you know, it's going to make it easier for me if you talk with me about this, because if something happens to you and I need to make a decision, I need to know what it is that you want. And I don't want to have to make something up. I want to really know so that if it doesn't go the way that we want it to, I'm not going to feel guilty. Now, maybe that comes from my Catholic, background of, well, if I tell them, what this really is about, and they feel a little bit guilty, they'll at least have that conversation with me. But there's a good reason for that, because what we're saying is really true. It will make it easier for you in terms of making decisions and making the grief. And so sometimes taking one piece of it at a time, saying, okay, I want you to start thinking about this. This is important to me. And in a month, I'm going to get us advance directives, and I want us to sit down and do this. If you're not ready right now, okay. But in a month, let's do this. And then sort of start to have that conversation. Or say, let's just do this. Let's get this over with. We're going to put it in an envelope. We'll put it away, and we don't have to talk about it again. And if you promise you're not going to talk about it every time, you sit down to have dinner, then maybe, again, people will say, okay, we'll do it once, we'll take care of all of this, and then let's not talk about it anymore. What do you think of those ideas? Do you think those would work?
Yeah, I think those are really helpful. I like how you said, it makes it easier for me if we do have this conversation, kind of turning it around. And I think those are really good ideas, so thank you.
You're welcome. And if you do have that conversation, I would love for you to call back and let me know how it goes.
Thank you so much. I will.
All right. Take care. So, and that's a real hard thing to talk about with family members, is that people, it's not a comfortable conversation for everybody. And so finding a way to make it comfortable, to make it palatable, and generally if it's because it's going to help you, people will be willing to do it.
Now we have a voice message.
Oh, okay.
So let's see what they have to say. They did not leave anything, even though I guess they decided not to leave anything at all. But the person who called 732-887-8242, please call in now because we have room for you. So please call in.
Excellent. Please call 484-258-1876, and we appreciate your questions. So I was talking about actually mortality rate, too. The mortality rates have to do with number of children born and the number of people who died. So things that affect mortality rates are sewage, how good our sewers are working, availability of nutrition, things like central heating, so that babies weren't dying with icy drafts, clean drinking water in terms of the path for infection.
Passionate World Talk Radio, you're on the air.
Hi, Lillian. This is Betsy.
Hi, Betsy. You have a question?
Yes, that was me. I didn't leave a message. I didn't know. Yes, I have a question. Since hospice, since people who have dementia fit a different criteria for hospice, when should someone look into getting their loved one on hospice?
So the question is, if somebody has dementia, when should they start hospice?
Yes, when should they start looking into it, since the criteria is different for a person with dementia versus someone with cancer?
Well, really looking into it in terms of, are they losing weight? So if they're having trouble swallowing and eating, would be one of the things to look into. Issues with incontinence, meaning they're not able to hold their bowel or their bladder. Their ability to walk and to move will impact how well they're able to breathe, whether that puts them at a risk for pneumonia. So basically, if you look at dementia or Alzheimer's type dementia, the later stages and risk for aspiration, when the food's not going down the right pipe and they're choking on their food all of the time. So that puts them at a risk for pneumonias. And also, I think as caretakers, the person the best. When they're not doing as well as they were. Wandering can be an issue in terms of safety, and where hospice can help is in terms of management of those symptoms, an extra layer of support for the caregiver, management in helping with grief issues, and also help with the bathing and grooming of the person. So often people will look at hospice and they think, oh my God, I don't want that place where everyone is going to die. And the reality is everyone's going to die no matter where they are. So more detail.
I was really shocked, like with Matt's situation, the nurse who did the assessment said to me, because you heard Matt talk, and she said, does Matt talk? And I said, yes. She goes, well, I'll pretend not to hear that so he could get on hospice. And then when his usual home nurse, hospice nurse came, she said to me, Matt talks? And I said, well, yes, sometimes he does talk in between, gibberish. She goes, well, if I hear him talk in 3 months, he can't be on hospice. And I was, are you kidding me? So you mean to tell me someone who's incontinent, hallucinating, barely could walk, because they could say a few words, they get denied? And I have heard that from other people. And she said that the criteria for a dementia patient, is different. So that's why I was, asking, like, if, your loved one is incontinent and has trouble eating, but yet at that moment of time when the nurse comes, they might say some intelligible words. I don't think it's right for them to be off the hospice just because of that. And, I would like to see Medicare change the criteria. I don't know, how that will, how it's going to work as baby boomers age. But I just think that they need to be more, more compliant and realize the situation of somebody with dementia could, say an intelligible few sentences while that nurse is there at that specific time, but they may not talk the rest of the day. And that's how, this disease goes.
The criteria are there as guidelines. They're not meant as check every single box and then they're eligible for the hospice benefit. And, back when hospice really kind of started in our country, and probably up until, I don't know, maybe the last 10 years, there were only registered nurses who were doing those intakes. And as you've seen hospices become privatized, become for-profit, there's been some change in terms of who's hired and who does the care. And there's been some studies shown in terms of how the care differs between for-profit and not-for-profit hospices. And the differences is the training, the education, and the percent or the hiring of registered nurses who cost more money than licensed practical nurses. And the difference in terms of education there has, without going too far down that rabbit hole, has in a lot to do with critical thinking. And able to look at criteria, look at data, and say, right, because they say a few words, they're not carrying on reasonable, coherent conversations that can verbalize their wishes and needs as somebody who doesn't have a cognitive impairment. Do you see the difference, Betsy?
Yes,
look at that.
Yeah.
They can say a few words. They can occasionally actually maybe even say if they want chocolate or vanilla ice cream. But are they able to verbalize their wishes and needs? And in a 24-hour day, no, and not consistently, and look at these other issues related to Alzheimer's that they're having. So that's the critical thinking. That's the assessment that a registered nurse will do in doing that intake. And I think that I worked as a hospice nurse, and it is stressful enough to be a caretaker in that situation without them saying, oh, they say a few words. Well, I don't know. They keep talking. We're not going to put them in hospice. It's like, oh, yeah, as a caretaker, you need that stressor. No, you don't. And so, yes, we absolutely have to follow the guidelines and the rules, but they're guidelines, and they're put through the lens of the
about that, and he was actually saying basically what you're saying, Maryanne, that, you know, they had to take the whole picture, the whole person in the situation, not just what happened in that 2 minutes or 5 minutes that nurse saw that patient, but the whole, you know, the weight loss, and, you know, they're incontinent, and, you know, they need wound care and things of that nature. But thank you, because a lot of people that I have seen in groups, they will, you know, say that, oh, we were denied hospice. And, you know, you ask, why were you denied hospice? Because they said my loved one can talk. And so I just wanted to listeners to, you know, to understand that, you know, they can question the hospice. They can go to Medicare, and they could do appeals, I mean, if they have to. And talk to the doctor.
Or the other thing they could do is they could look for a not-for-profit hospice, and they might get a totally different determination from them. And if you're in a state that has a lot of different hospice companies, go to a different one. You don't have to just go with the very first one that you chose, unless you're in a city where there's only one. But you know, they're companies, and so find a different one, get a different assessment.
Very good. Thank you, Maryanne.
And I'm sorry that happened to you and to the other people that you've heard. That's, to me, very inappropriate.
Okay, well, thank you. I'd like your advice. Thank you very much.
I appreciate you. Thank you.
Bye-bye.
So I was talking about life expectancy, and it's something that's sensitive to the reductions of death rates of children, because each child that survives has many years the amount of life in the population. So there's dramatic declines in infant and child mortality in the 20th century was accompanied by equally stunning increases in life expectancy now. So for white women, life expectancy at birth rose from 51 years in 1900 to 81.1 years in 2116. And for white men, the life expectancy at birth rose from 48 years in 1900 to 6.1 years in 2017. And I'm giving white men and white women because there's other factors that play into life expectancy for other groups. So if you're interested in looking at life expectancy, you can go to the CDC website or just look up life expectancy for your particular gender and race, and you can get a sense of about what your life expectancy is. But we tell people that there's three reasons that people die. The question of why do people die? There's three reasons that people die. They die because they're very, very sick, they're very, very hurt, or they're very, very old. And this is something that you can tell very, very young children in terms of why do people die. Everyone dies, and that is a fact that I think that children should know, and that adults should know that there's just no way around that one. And there's only three reasons, meaning that if you're very, very sick, that there's an illness that the body cannot recover from, be it a virus or a cancer or heart disease or Alzheimer's disease, whatever it is, there's at some point that the body may not be able to recover. The second reason is they're very, very hurt. I mean, if you fall off a 20-story building, you're not going to survive. If you're run over by a car, you're not going to survive. So very, very hurt is something that happens to the body that it can't recover from an accident or something of that nature. And very, very old is the third reason, is our bodies are not meant to last forever, and that there's what's in gerontology call the wear and tear theory, where all the parts wear out, and the body needs certain things in order for it to work, and when those things don't work, then the body will die. And maybe I'm making it sound very simple, but it is pretty simple in terms of answering the question of why we die. So Lillian.
Yes.
How's our time doing?
Well, I think you can wrap it up.
All right. Well, I really appreciate everybody who called, and I hope that those that are listening will mark your calendar and call in with questions. Thank you for spending time with me during our show, Everyone Dies. You can read our blogs and listen to our other podcasts at everyonedies.org. It's EDERY, the number 1, dies.org, as well as listening to our shows on Passionate World Talk Radio on Spreaker, and our shows wherever you listen to podcasts. We're here every Wednesday at 6 p.m. Eastern Standard Time to take your calls and answer your questions related to life-threatening illness, dying, and death. I hope that you live your best life every day, and remember, every day is a gift. Thank you for listening. Goodbye.